All right, in this guide, we're going to break down a procedure you will definitely see in your training, percutaneous transhepatic cholangiography, or as we all call it, PTC. It's an absolutely crucial skill in interventional radiology, especially when you're dealing with those tricky cases where the usual approaches to the biliary system just won't work. So let's get right into it. Here's how we're going to tackle this. We've got 5 main parts. We'll kick things off with what PTC actually is. Then we'll jump into how you pick the right patient, get them prepped, walk through the procedure itself, and wrap up with post-op care and what to do when things don't go perfectly. So first up, let's cover the basics. What exactly is PTC? And, where does it fit in the grand scheme of things when you're managing a biliary obstruction? At its heart, PTC is really all about creating a roadmap of the biliary tree. Think about it. Percutaneous means we go through the skin, and transhepatic means we go through the liver. So we're using a needle to go straight through the liver and into a bile duct. Once we're in, we inject contrast, and boom, the whole system just lights up, showing us exactly where the problem is so we can fix it. Now, this is a really key point. PTC is not the first thing we reach for. That's usually a procedure called endoscopic retrograde cholangiopancreography, or ERC. But what happens when you can't do an ERC? Well, that's when PTC becomes the hero. It's the problem solver for all those complex cases that can't be handled the standard way.
Okay, so now that we've got the basics down, let's shift gears to something just as important, patient selection. How do you figure out if your patient is actually a good candidate for PTC?
This is the big question, right? PTCI isn't for every single biliary problem. So let's dig into the specific things that should make you think, maybe we need to get IR on board. So the big reasons for PTC almost always come down to access. Take a patient with a Roux-en-Y gastric bypass, for example. Their anatomy has been rerouted, making it pretty much impossible for an endoscope to get where it needs to go. Same deal with a tumor blocking the way. And then you have conditions like primary sclerosing cholangitis, where the biliary tree is full of tight spots and strictures. An ERC might not give you the full picture, but a PTC can give us a much better view and a way to intervene. It's really important to get this. There aren't any absolute reasons not to do a PTC, just relative ones. And that means they're not roadblocks, they're just challenges we need to manage beforehand. For instance, if a patient has a bleeding disorder, we have to get their clotting factors in a good place. If they have a ton of ascites, that fluid has to be drained first. Even when the ducts aren't dilated, which makes the procedure way harder, it doesn't automatically rule it out. It's all about weighing the risks and benefits. Okay, next section, the prep. Careful, detailed prep work is really the foundation for a safe and successful PTC. You can't skip this stuff. This medication timeline is absolutely critical. We're talking blood thinners, like warfarin and clopidogrel. Those have to be stopped 5 days out. The newer ones, the DOACs, need to be stopped 2 days before. And then right before the procedure, we give prophylactic antibiotics like ceftriaxone to head off any infection. It's just as important to have a solid plan for when to restart all these meds afterwards, too. Here's your final pre-flight checklist. First, you've got to review the labs, paying super close attention to the INR and platelet counts. Next, pull up all the prior imaging, CTs, MRIs, whatever you have, to map out the anatomy and plan your attack. And of course, you have to confirm the patient has been NPO and that everyone's on the same page about the sedation plan. Okay, prep is done, patient is ready. Let's head into the IR suite and walk through how this procedure actually goes down. So the very first decision is, where are we going in? The right-sided or intercostal approach is super common, but because you're going between the ribs, it can be more painful for the patient. The left-sided or subcostal approach avoids the ribs, which is nice, but it does carry a slightly higher risk of hitting an artery. It's a classic clinical trade-off, and the radiologist will choose based on the patient's specific anatomy and their own preference. The whole procedure can really be broken down into 3 main stages. First, using imaging to see what we're doing, we guide a tiny needle into a bile duct out on the edge of the liver. This takes a lot of precision. Second, once we're in, we inject a little puff of contrast to confirm we're in the right spot. Then we thread a guide wire into a bigger, more central duct. And finally, we slide a drainage catheter over that wire, navigate it past the blockage, and place the tip in the duodenum. And just like that, we've reestablished the natural flow of bile. Okay, listen up, because this is a huge safety tip, a real pro tip. Before injecting a whole bunch of contrast to light everything up, the radiologist will first let some bile drain out.
Why? Well, think about it. If the system is blocked and under high pressure, injecting more fluid can actually push bacteria into the bloodstream and cause biliary sepsis. Decompressing first is a simple but absolutely vital step to prevent a really serious complication.
So the procedure is over, but our work isn't done. Now it's all about the follow-through, watching the patient closely and knowing what to do if complications pop up. This chart gives you a pretty good idea of the risks. The big stuff, the major complications like a bad infection or serious bleeding, happens in about 4 to 9% of cases. But look at that range for minor complications. It's huge, anywhere from 2 to 38%. That big range is exactly why we have to be so vigilant after the procedure, and it's why most patients stay overnight for observation after their first PTC. So when we say minor complications, what are we really talking about? Well, most of the time it's issues with the catheter itself. As you can see here, a blocked catheter is the most common problem at about 8%. Then you've got the catheter getting pulled out of place at 6% and some leakage around the site at 3%. As a trainee on the floor, these are the things you need to be watching for because a clogged drain can lead to a fever and cholangitis really fast. A hepatic arterial injury, this is one of the scarier bleeding complications. It happens in about 2% of cases, and it leads to something called hemobilia, which is literally bleeding directly into the bile ducts. Now, this is definitely a serious event, but the good news is that the IR team can almost always get it under control with a procedure called transcatheter embolization. So let's end with this clinical scenario. You get a call. Your post-PTC patient from yesterday now has a fever. What's going through your head? What are your first thoughts? Is it cholangitis? Could the drain be blocked or out of place? This is where everything we just talked about comes together, from the risks of the procedure to the nitty-gritty of post-op care. Knowing what to look for, well, that's half the battle.